So there are several parameters that we can assess while radiologically discussing the CV junction parameters. So these are cranial landmarks, craniocervical, occipito-atlantal relations, as well as atlanto-axial relations. So I'll just go through them in brief. Coming first to the cranial and craniocervical relations. So we know that we have several lines here. One of the most common and the oldest one that was described was Chamberlain's line, which is basically a line drawn from the posterior aspect of the hard palate to the tip of the opistheon, that is the posteriormost tip of the foramen magnum. In many times, if the dens is above 3 millimeters, it's suspicious of BI, and if it is more than 7 millimeters above that, it is indicative of a definite basilar invagination. This doesn't assess the atlantoaxial translational instability per se. Now, because in olden days, in X-rays, the posterior, that is the opistheon, was not clearly visible. That is why McGregor modified this into a line that was drawn from the posterior end of the hard palate to the squamous portion of the lowermost tip of the occiput, that is the squamous surface of the occiput, that was clearly visible on the X-ray. And this, obviously, this was a line that was below. So if the dens goes more than 4.5 millimeters above, and in several studies it has been discussed that in males and females, because of the change in the contour of the occiput, more than 7 millimeters in male and more than 10 millimeters in male is indicative of a basilar invagination. So this is how we measure nowadays. It's quite easy with X-rays and MRI. Macrae's line is one of the easiest lines to draw between the basion and the apestheon. It basically measures the anteroposterior diameter of the foramen magnum. If it is less than 19 millimeters, usually it's around 25 to 35 millimeters, so it's less than 19 millimeters, it's suggestive of primary foramen magnum stenosis and cord compression, and also if the dens goes anywhere above this Macrae's line, it's suggestive of basilar invagination. Similarly, Claus height index measures the depth of the posterior fossa per se, which is a line drawn from the tuberculum sellae to the internal occipital protuberance, and the distance between this line and the tip of the dens or the foramen magnum level. So this is the Claus height index, which normally is around 40 to 45 millimeters. Naturally, when the basilar invagination is there and the odontoid moves up, if it is less than 30 millimeter, if the distance is less than 30 millimeter, it indicates of basilar invagination. It can also be this is not an isolated parameter. This height can also be reduced in primary posterior fossa height reductions like low-lying torcula, small posterior fossa size, in all those things. So we should be careful while interpreting this line. Bimastoid and digastric lines are measured in the frontal plane, and usually the bimastoid plane is a line that is drawn between the tip of mastoid processes. The digastric digastric line is the one that is drawn between the digastric grooves, that is at the base of the mastoid processes where the digastric muscle originates. And usually the odontoid is, if it goes 10 millimeters above the bimastoid line, and if it reaches within 10 millimeter of the bimastoid line, digastric line, that means it is suggestive of a basilar invagination. One of the simplest line again is the Wackenham's clivus canal line. It measures the internal slope of the clivus per se. If the line, when it's extended into the canal, if the dens goes above this line, that's again indicative of a basilar invagination. Usually this line should be tangential to the posterior aspect of the dens per se. When this line is combined with the Harris line, that is a line that is drawn along the posterior border of the spinal canal or the posterior border of the axis. So this angle is called the Wackenham's clivus canal angle. So when this angle increases, when the odontoid retroverts and actually migrates inside the foramen magnum, this angle can get reduced. If it's less than 150, it is suggestive of impending spinal cord compression. Another important thing to measure platybasia is there are two angles, that is the basal angle as well as the Bogart's angle. Basal angle is the one that is along the base of the skull as well as the plane of the clivus. So as it has been shown here, if it is more than 145, usually the clivus is more flatter. If it is more than 145, it indicates platybasia. Similarly, Bogart's angle, it's almost similar. Again, the clivus angle, it measures with the level of the foramen magnum or the Macrae's line, basically the angle between the Wackenham's and the Macrae's line. So again, if it is more than 136, it is suggestive of platybasia. So basically, this is the relationship. So usually the skull base, the anterior part of the skull base, that is the line drawn from the nasion to the tuberculum sellae, or the midpoint of the tuberculum and the dorsum sellae, and the Macrae's line are usually more or less parallel. It need not be always. It can change depending upon the abnormality that we are dealing with. So both of these angles increase whenever there is a platybasia. Bull's angle basically is an indirect measure. So usually it's an angle that is drawn between the Chamberlain's line and the plane of the atlas. So the impression is that whenever there is a retroverted axis, whenever the retroverted axis is there, the atlas also goes back, so that this posterior angle that is there, that is observed between the Chamberlain's line and the plane of the axis, increases. If it is more than 13, again it suggests platybasia because of the because of the inclination of the clivus. Ranawat method, as we all know, it's a simple thing that is drawn between the axis of the atlas as well as the center of the C2 pedicle, the distance. Again, if it is less than 15 in males and less than 13 in females, it is suggestive of a bacilli invagination. This is one of the recent things that have come up, craniocervical tilt, discussed by Dr. Chandra. So again, this measures the anterior slope of the clivus and the anterior slope of the axis. Usually, again, in normal subject, it's somewhere supposed to be 50 to 70, whereas if it is more than 70, it usually indicates not only BI, but usually AAD. Compared to the other parameters, the authors claim that this craniocervical tilt not only provides about BI, but also the upward as well as backward, the retroverted nature of the axis as well. That is the advantage of this. Coming to atlas and the relations between the atlas and the occiput, atlanto-occipital axis angle is one of the important ones. So where, usually the angle is around 124, 127. In condylar hypoplasias, this angle can be more than 127 because of the flat nature of the joints, of the occipito-cervical joint space. Perhaps the most important measure in atlanto-occipital relationships is the Harris rule of 12. So where the distance between the tip of the basion and the posterior axial line, that is the BI and BDI, both should be less than 12. So this is the rule of 12 that is measured. We all know about the powers ratio. So we measure the BC by OA. Usually the distance should be equal. So whenever there is a translocation of our atlanto-occipital dislocation, so it can actually vary whether it can less than 1 or more than 1. Least X lines, again, we already know, I'll not go into the details. CCI is also a very important parameter that we need to see while assessing OC1 relations. Atlas axis relations, we know that anterior atlantoaxial as well as lateral atlantodental interval are the important ones. And anterior atlantodental interval is less than 3 millimeters in adults and less than 5 millimeters in children. And lateral atlantodental interval usually is around less than 3, and there should be less than 2 millimeter difference between the two sides. We should also look at a close this one between the joint spaces as it is shown in this X-ray. So it's not just important to measure these parameters, it's also important for us to classify or tell how to use these parameters in different instances and how to classify these bacilli invagination. I'm sure the authors coming forward are going to discuss more in detail. Just to give a brief glimpse, so this can be around type 1 and type 2 bacillar invaginations, where usually between Chamberlain's line and the Wackenham's line, if the dens is above the Chamberlain's line, but it's below the Wackenham's line, so usually it suggests of a type 2 bacillar invagination, whereas if the dens is above both like the Chamberlain and the Wackenham's line, so usually it is suggestive of a type 1 bacillar invagination. We should also look at the associated anomalies that are there in these cases, congenital CV junction abnormalities like atlanto-occipital assimilation, which can be complete or partial, different anomalies of the dens, most importantly to differentiate whether it's an ossiculum terminal or an os odontoideum, and of course, rare abnormalities like condylus tertius, condylar hypoplasia, and associated Chiari malformations. To summarize, there are a multitude of indices to assess relationships at CV junction. Most important one for platybasia, it is the basal angle, which is equivalent to a Bogart angle, as I've already told. To assess bacillar invagination, Chamberlain's and Wackenham's line, usually these two are the ones that can be used to classify and differentiate bacillar invagination. Atlanto-occipital junction, Harris rule, and condylo C1 lateral mass interval, that is the one that the joint are the more important ones. Atlanto-axial joint, anterior as well as lateral atlantodental interval are the important ones. Thank you.